Welcome to part 3 of the series. Here we shall be discussing about metabolism of carbohydrates, fats and proteins, also the surgical metabolism during fasting and during trauma. Carbohydrate makes up around 45% of the diet, of which 50% is starch and 50% are sugars from milk, fruits and vegetables. The salivary amylase is the one which starts the process of the digestion, but the major enzyme is the pancreatic amylase, which causes the starch to get digested and break down into oligosaccharides and alpha limit dextrins. Now these sugars, along with the other dietary sugars, can't be absorbed. Therefore the brush border hydrolases cleave them further in the villi of the duodenum and jejunum to form glucose, galactose and fructose. Fructose goes into the cell with the glucose transporter 5, and it gets out of the cell going into the venules of the portal system with glucose transporter 5. Whereas glucose and galactose are transported into the cell by the sodium glucose transporter, and they are transported out of the cell into the venules of the portal system with glucose transporter 2. 10 to 15% of the diet consists of proteins. In addition to that, 50% of the proteins entering the small bowel are GIT secretions and desquamated epithelial cells. Quite a bit, huh? The pepsin in the stomach starts the process of the digestion, followed by the pancreatic enzymes, mainly the peptidases, which are released as proenzymes. In the presence of bile acids, enterokinase from the intestinal brush border catalyzes the conversion of trypsinogen to trypsin. This finally activates other proteases. The proteases break up the proteins, and finally the peptides are broken by the peptidases. The amino acids are absorbed via the membrane-bound transporters, and then they enter the portal system. Glutamine is unique, as you have seen in other videos, because it's a major source of energy for the enterocytes. 40% of the diet consists of fat, 95% of which are long-chain triglycerides, and the rest are fatty acids, cholesterol and vitamins. 94% of the fat is absorbed in the proximal jejunum. The mechanical process of mastication and even the mechanical peristalsis helps to solubilize the fats. The salivary and the gastric lipases are acid lipases, which start the digestion, whereas the pancreatic lipase, which is an alkaline lipase, is the main catalyst for the fat breakdown. Along with the mechanical action, the bile acids form micelles having a core of fat and a hydrophilic surface on the outside. These, when delivered to the brush border, get the fat absorbed because the lipases act on the small molecules, and the lipases, when they are broken up, the lipids, when they are broken up into glycerine and fatty acids, get through the brush border. The mechanism is not so clearly understood, but once the long chain fatty acids are transported across the brush border, which are transported using the fatty acid binding proteins, inside the enterocyte they are reconstituted to form triglycerides. Here they are attached to chylomicrons and secreted into the intestinal lymphatics, which goes into the thoracic duct, into the venous system and directly into the capillaries. The short chain and medium chain fatty acids are absorbed without any intraluminal hydrolysis, so you don't need to break them up inside the lumen. There is no need of micellar solubilization, there is no need of mucosal reesterification, and there is no need of chylomicron formation. All these steps occur only for the long chain fatty acids. Instead, medium and short chain fatty acids are directly absorbed into the portal circulation rather than the lymphatics. And this is the rationale of using medium and short chain fatty acids in enteral nutrition. The fat soluble vitamins are absorbed through passive diffusion. Vitamin K is both active and passive. There are specific carrier mediated transport for vitamin C, folate, vitamin B2, riboflavin, pantothenic acid and biotin. Cyanocobalamin or vitamin B12 is bound to salivary R protein. The pancreatic enzyme lyses this R protein, and then cobalamin binds to intrinsic factor. This escapes hydrolysis by the pancreatic enzyme, reaches the terminal ileum and is absorbed there. One of the most important steps is cellular respiration, which is basically the part of glucose metabolism. Glucose is a 6-carbon ring, and when it gets burnt, it gives off CO2 and H2O, and also it gives off 38 ATP. This is the same process as you would burn any fuel, but the only difference is that this process occurs inside the cell, and it goes through 3 phases. The first phase of glycolysis, wherein glucose gets converted to pyruvate, it generates 2 ATP. This is an anaerobic process. Now, if this pyruvate doesn't go to the second and third phase, that's when it gets converted to lactic acid. So if there is no oxygen in second and third phase, you have lactic acidosis, and this is what reflects in your ABG. And there could be so many reasons for lactic acidosis. It could be shock, that blood doesn't flow properly, so there is lactic acidosis. Obviously, when there is shock, there is even lack of oxygen. If there is hypoxia, you will have lactic acidosis. In severe bleeding, because there is a hypoperfusion of many other tissues, there is lactic acidosis. So now you know the basic mechanism from where you get this lactic acid. The second and third phases are aerobic. The second phase is the Krebs cycle, which generates 2 ATP. And the third phase is the electron transport chain, which occurs in the mitochondrium, which generates 34 ATP. So this is how a molecule of glucose, when it gets burnt, first initially through anaerobic, and then through an aerobic process, gives off 34 ATP. Totally 38 ATP. The brain, retina and the kidney depend entirely on glucose, but that can change on fasting. And the blood glucose level is usually very tight, between 60 to 150 milligrams per deciliter. The glucose can also be condensed into glycogen. That means there is a removal of water, and this glycogen is preserved in the liver and the muscle. And an average human being has around 400 grams to 450 grams of glycogen stored in the body. And these stores can last for anywhere from 10 to 16 hours. Gluconeogenesis uses lactate, the same lactic acid which we talked about, pyruvate to lactate business, and amino acids to produce glucose. So this occurs whenever the glucose values are low. If one takes a ratio of NAD plus is to NADH in the cell, it is 1000 to 1, telling you that there is a lot of NADH. Basically, they want to accept electrons, and thus this favors the breakdown of glucose, and this favors the production of energy. At the same time, you take the ratio of NADP to NADPH, it's 1:10, which means to say that the primary role of NADPH is to donate electrons, which helps to build up fatty acids, and it also, in addition to that, has an antioxidant property. Therefore, we have understood the digestion and absorption of fats, carbohydrates and proteins. We also understood the main source of energy, that is cellular respiration. The next thing we go on to is the storage of fuel. You know that glucose becomes glycogen because of condensation, and it's stored in the liver and the muscle around 450 to 400 grams in a 70 kg male. That means to say that per day you can roughly get around 2000 kilocalories from the stores of glycogen. And proteins, mainly in the muscles, you have around 6 kilograms of proteins in a 70 kg male. That will give you around 24,000 kilocalories. So that means to say you can last for 12 days. But if you last only on proteins, don't forget that you will burn up all your muscles, including the diaphragm, and you will not be able to breathe. So that's disastrous, isn't it? As far as the fats are concerned, you have roughly 12 kilos in a 70 kg male. A chap like me, I don't know, maybe you have 40 kilos. Oh, fat guy, isn't it? So that gives you 108,000 kilocalories. So you can last for almost about 2 months with that. Now if you compare why do you have fats instead of glycogen in your body, just imagine if you store glycogen. It's a very heavy molecule and gives you a lot lesser energy. So if you check the biology and chemistry there, you'll realize that it's better to have fats as opposed to having glycogen as stores. Now fats have a lot of bonds. It can be oxidized to produce ATP. At the same time, they're inert, they're not reactive, and they do not have any other functional role other than energy storage. Now that we understood how the body stores the energy, let's check out the metabolism during fasting. To maintain the basal metabolic rate, during the resting phase, an average adult needs around 22 to 25 kilocalories per kilogram per day. And these calories come from carbohydrates, fats and proteins. Now if the stress level is really high, one would need around 40 kilocalories per kilogram per day. As you've seen, the glycogen is around 400 grams and 100 grams of this is in the liver, the remaining is in the muscles. Whereas the muscle stores are not readily available for systemic use because of the deficiency of glucose 6-phosphatase. Therefore, you know that to glucose 6-phosphate to glucose 1,6-biphosphate and blah blah blah. This is the cycle, isn't it? Now the liver stores get depleted in the first 16 hours. Now during fasting, the body needs up to 180 grams of glucose per day to support the metabolism of the brain, RBC, WBC and the renal medullae, also including the intestinal mucosa and the skeletal muscle. So what happens when the glucose or the glycogen gets depleted? That's when you need gluconeogenesis, which is mainly from lactate, which comes in from the cycle, also from glycerol and the amino acids alanine and glutamine. Now the Cori cycle will take pyruvate and get it back to lactate. So where does it get the pyruvate from? From all the body tissues, and it takes it, shunts it back all the way to the liver to form the new glucose molecules. So to produce this extra glucose from gluconeogenesis, you need at least 75 grams of protein per day to get degraded to provide the amino acid substrate for hepatic gluconeogenesis. Now if one would check as to how much nitrogen do you lose per day on an average, you lose around 7 to 10 grams per day. This can increase up to 30 grams per day and it slowly reduces to 20 grams per day of proteolysis and almost up to 2 to 5 grams of nitrogen excretion per day, which reflects the adaptation of the vital organs to use ketone bodies as a source of fuel as opposed to using proteins, which finally goes into gluconeogenesis. So during prolonged fasting, ketone bodies become the fuel for the brain after 2 days and the principal source after 24 days. It takes roughly about 3 weeks. The kidneys, they utilize glutamine and glutamate for gluconeogenesis in prolonged fasting, and they produce up to 50% of the glucose in prolonged starvation. The fat that is stored in the adipose tissues provide 40% of the calories during starvation. You need roughly 160 grams of fatty acids and glycerol per day, which are mobilized to provide energy. Now the free fatty acids like ketone bodies are used as a fuel by tissues such as the heart, kidney, muscle and the liver, which are the most important organs being used during the intense phases, during stress and trauma. Now once the lipid stores get mobilized, this reduces the rate of glycolysis, gluconeogenesis and proteolysis. So therefore you reduce the overall glucose requirement to sustain the host. Furthermore, ketone bodies spare the glucose utilization by inhibiting the enzyme pyruvate dehydrogenase. Now the metabolism during fasting is taken something like a backbone or a yardstick to understand the metabolism during injury. So basically you will get the fact that when one fasts, he loses the glycogen. So he uses roughly about 180 grams of glucose per day, and to get that stuff you will be eating around 75 grams of protein, and to prevent both of them getting chewed up you will need roughly about 160 grams of fats per day to sustain everything. So if all goes well, you haven't caused much damage to the system. But supposing there is injury and the subject is unable to feed, that's when all hell breaks loose. Now that's when the lipid metabolism after injury will get kicked in. Now remember that these lipids also influence the structural integrity of the cell membrane and also the immune response during the systemic inflammation, because most of the cytokines come out from there. At the same time, the lipolysis of the adipose tissues occur after injury, and this accounts for almost about 50 to 80% of the energy source, as opposed to 40% of the energy source during fasting. The liver cells, they use free fatty acids as a dietary source during stress. The muscle and the heart, they use chylomicrons and triglycerides. The basic idea is the lipoprotein lipase. This enzyme activity is usually suppressed in trauma by the action of TNF. Alright? Now during the high energy demand, free fatty acids are mobilized from the adipose tissue, and the triglyceride lipase is responsible for that. And this basically gets upregulated or stimulated by the actions of ACTH, T3, T4, catecholamines, etc., which are released during stress. The fatty acids basically enter the capillaries and they are utilized by the muscles and the hearts. Now the thing that you should remember here is the basic biochemistry. Remember the glucose, which it has to first undergo an anaerobic metabolism, and then it's aerobic to the Krebs cycle, and finally in the electron transport chain. The electron transport chain business occurs in the mitochondria. So the fatty acids which are taken to the capillary after breakdown from the adipose tissue through the action of lipases and blah 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 has to finally be absorbed around the body tissues of the capillaries, and you know capillaries are everywhere in your body. So when this occurs, these fatty acids will go in and get oxidized. Okay, there is an oxidation of the fats, and every time there is an oxidation of fat, there is getting released a molecule of acyl-CoA, and this acyl-CoA is transported into the mitochondrial membrane by the carnitine shuttle. Now once this gets into the mitochondrium, here there is going to be a metabolism of acyl-CoA, and then this is going to start releasing ATP. Alright, so when the fatty acids undergo the beta oxidation, every molecule of acyl-CoA will give you 12 molecules of ATP. So this shows you that fats can give you a hell of a lot of energy, and when the patient is fasting or when he has gotten injured, that means fasting for a very long time, a lot of energy is being given off by the fats. So this is how it can act as a good source of energy during the injury, stress and trauma. We had noted earlier that you need roughly about 180 grams of glucose per day from gluconeogenesis to sustain the cells, and this is got from 75 grams of protein. And later, as this process is prolonged, you need roughly about 160 grams of fats to solve the issue and give you energy. During starvation, the gluconeogenesis occurs at the expense of skeletal muscles. Therefore, glucose has been administered to have a protein sparing effect. But in trauma and septic patients, the administration of glucose does not really suppress the amino acid degradation. Studies have shown that insulin administration can reverse the protein catabolism because of the direct action of insulin. It's an enzyme, it's a hormone which helps to build up the proteins. Okay, so at this point of time, when you administer insulin, you can tell whether the glucose is being used as a source of energy by actually checking the respiratory quotient. Now during sepsis, there is going to be a glucose intolerance because of reduced activity of pyruvate dehydrogenase, and you have seen this similar thing when we talked about the fat metabolism also, that the fats try to down-regulate this enzyme. This enzyme is used to get pyruvate into acetyl-CoA. Thus there is a reduced amount of pyruvate which is available to go into the Krebs cycle, and pyruvate and lactate are then shunted to the liver as a substrate for gluconeogenesis. Now this response again is not suppressed by the administration of glucose. Now the next topic that we talk about is shown in a graph in the future video. Daily there is going to be a proteolysis which occurs after trauma, as I said, 75 grams per day, and this will keep increasing up to 30 grams a day of lean body mass to up to 1.5% of lean body mass. So a person who doesn't receive any nutrition for 10 days can almost lose around 15% of his lean body mass, which means to say that's a hell of a lot of protein, considering you have only 6 kilograms of protein in your body. That will lead to muscle weakness, inability of a person to utilize his muscles completely, which even means to say that his respiratory muscles can get weak. It will be difficult to take him out of the ventilator. This will increase the hypercapnia, and one by one it will have even effects on the acid-base metabolism. So I've shown the graph in the future video, and that will give you a clear picture as to what really goes on. Thanks for watching. I hope the topics have become a little clear, and please like, subscribe, comment, or email me.